kick into our session. So opening us up with karakia. Tūtawa mai I runga, tūtawa mai I raro, tūtawa mai I waho, tūtawa mai I roto, kia tau ai te mauritu, te mauri ora, ki te katoa, haumi e huie, tae ki e. I ngā mana, I ngā reo, rau rangatira mā tēnā koutou, tēnā tātou katoa. Welcome to the Collaborative Aotearoa webinar on paramedics in primary care. I have said probably repeatedly across the last maybe 4 to 6 weeks that this is my new favourite profession in general practice. I feel like they're making such an impact and coming in strong. So it's been a real privilege to be able to work with the people on the screen, but also with the wider community around the impact and inclusion of paramedics and ECPs into our general practice workforce. So tonight we're excited to share with you some of the learnings from the working group that Collaborative Aotearoa has hosted over the last few months, but also kind of get some of those niggly questions out in the open that I'm sure many of the people on the either watching the recording or on the session live tonight have been thinking about and asking themselves. If you've got questions that we haven't answered or we haven't got covered tonight, do use the Q&A function, jump in there, put your questions in. I'll be moderating them as we go and making sure that we get all of your questions answered. Any that we don't answer live tonight, we'll take offline with our panelists and circulate them around with the recording. So do feel like you can, get deep with some of your questions and make sure that you leave feeling really informed about the inclusion of paramedics and ECPs in general practice. So just a little bit of whakapapa. Collaborative Aotearoa a couple months ago, we're given a little bit of a challenge from our colleagues at Tora Compass who said, hey, can you do a bit of work on paramedics in primary care, because there's a bit of a space that needs to be covered here and it should really be done nationally. So we took up that rākau from Louise Poynton and Byron at Tora and went, okay, let's do that. We started a working group where we included a series of our members from across Aotearoa and a whole lot of different people. So we had St John in the room, we had Wellington Free in the room, we had Jacqueline from the Paramedic Council in the room, and we had a whole lot of ECPs, a couple of the ones on the screen. We were informed by people like Sean and GPs and other people who'd been exploring this space, and we created a toolkit to support general practices to employ ECPs or paramedics within their practice. So instead of you having to do that thinking or do that research all over by yourself, we tried to consolidate as much of that information as possible into one place to make it nice and easy to bring this workforce into general practice. So we're going to learn a little bit about that tonight, but I just wanted to kick off, and for those that came early for the bloopers, we will talk a bit about the standing order, I guess, challenge. So paramedics and ECPs are a massive resource to our general practices when they can work at top of scope, which means that they need to be working under standing orders. There's not been a nationally consistent approach to standing orders in Aotearoa, not for our nursing workforce or any other workforce. And so we've kind of been posed a little bit with this challenge around how do we get some national consistency for ECP and paramedic standing orders. And a part of that is, can we just get some career agnostic or profession agnostic standing orders as well? So for some that could cover both nursing and paramedic as well. So there's not necessarily just have to be paramedic or ECP ones, but actually can we have some consistency? So the working group have worked through as a team and as a group about 25 standing order templates. For those that are coming in from Canterbury, we're not quite at your level yet. We haven't got these built into pathways. We are still working on the template model. And then we've also just received about 45 standing order templates from Southern. So those have been I guess, established and written and had governance over them from the Southern team. So that's Health Pathways and also Well South have been kind of contributing into that space. So we've now got ourselves a little bit of a kitty of standing orders. They are just going through a review process. So we've got a clinical pharmacist from the Hawke's Bay, and we've got a ECP from Auckland having a look at them at the moment, and we'll also get GP kind of eyes over them before we share them out nice and wide. I can give you the 45 from Southern, so we will find a way and a mechanism of getting those available to you. They are due for clinical review in August, so if you're really desperate for something before August, we can share them, but if you can hold off until the end of August, we'll make sure there's been a clinical review of those before we kind of put them up on our website and make them really publicly available. Now, because Te Waipounamu are kind of leading the show in this space, I'll give them a little bit of a limelight here. They are doing a bit of a regional approach and doing some regional thinking about standing orders. This work has been run and led by Jill Clendon, and she's doing an incredible job around trying to figure out what this looks like for the South Island, for Te Waipounamu. And that approach is looking like that will roll out across the country. So once they nail it, we'll be able to make that kind of nationally consistent. So there is some work regionally, nationally going on in the space. It is being coordinated. This work is linked into it. But it just is going to take a little bit of time. Our end goal is for all of these templates to be on Health Pathways and to have really nationally consistent clinical governance falling through and running through them. And then I guess the gold standard, which Canterbury you've experienced for the last few years, is that they'll be woven into the pathway as well. So it'll be really simple and easy for the professional person to come into that space, follow the pathway, and then the standing order will be in there. So watch that space as it evolves. As we know, our beast is a little bit slow at the moment, so that might take a little bit longer than expected, but that's kind of the staged approach of where we're working towards. So sorry to take up the first kind of 10 minutes, but I just wanted to let you know that there is some stuff going on in that space. We are really actively aware of the raru and the tension that's happening in that space, and just wanted to kind of share with you where we're at and that we're definitely aware of all the things that are going on. So on that note, we're going to hand around to our panelists to introduce themselves. We've got a great lineup for you tonight. And with that, we'll also get you to answer the first question. So a little bit of whanaungatanga, but we'll also crack you with the first question, which is, could you share with us some of your initial thoughts and learnings about bringing paramedics into the general practice space? You're all going to come at this from a slightly different approach and a different experience, but really keen to know what this has meant for you and what you've experienced in seeing this profession come into general practice. So we're going to open up with Chris, and then we'll go to Sean, we'll go to you, Jacqueline, Byron, and then we'll finish with you, Shell.
Kia ora everybody, my name is Chris Iwiko. I am a paramedic working in a general practice. We have about 20 GPs in our practice, and we've got about 25,000 registered patients that we have under us. So the journey for myself getting into primary care was about 4 years long after a smart remark to a GP with his foot up on the desk one day when I turned up in an ambulance to pick up a patient off him and said, I need a job like yours, sitting around waiting for someone else to do your work. And he was determined that one day he'd make it happen. So about 12 months ago, I got a phone call from our local practice and said, hey, look, we want to look at bringing someone into our acute care space. We have a lot of people that walk in. We're not an A&M centre, but we're semi-rural and feed a large rural population. So we have a lot of people that will turn up just to try their luck before trying to head through to a hospital or to an A&M centre in a city not far away. So that journey for me was hey, let's sit down and see where this could work within a general practice or within the practice that I'm working in, what I could bring to the table in terms of my clinical skill sets and experiences, and what the general practice wanted to bring to it. What did they want to achieve out of it? And part of the first conversation we actually had was, the medicine's the medicine, we all do it practically the same way, but what does the business want to achieve by adding something else into its mix? Because we're going from an old-fashioned doctor, nurse, GP type setup to now we're bringing in things like health improvement practitioners, paramedics, health coaches, and all those sorts of things. So it's now becoming a group approach, or a large group approach to what used to be a very linear model. It had to work for the patients, it had to work for the centre, and it had to work for the clinicians, because it's a big change from having people following their day-to-day to having someone who works autonomously under their own sort of skill sets in a centre, which they haven't had before. So I think there's a lot of learnings to be done from both sides. I think one of the biggest things is that in general practice, unless they've sat down or done a lot of work with paramedics or ECPs, they actually don't understand the large scope that they're working under, and what they can actually achieve as part of the team, but independently working on their own. So for us, it's brought some really good benefits, which we'll talk about later on. But I think initially you've got to be open-minded, you've got to have a plan, and you've got to have a pathway that's not just, let's get you in because there's so many numbers walking through the door, you can start ticking patients off. It's, where do you want this to go? What aspect do you want them to do, whether it's acute care, long-term conditions, or just general duties type stuff, and plan your attack around that and go from there.
Kia ora.
That's me.
What a great intro, and so interesting to hear the different perspectives. So great to have you share your journey into practice, and have that authentic introduction into the space. I think sometimes we make all of these things a lot prettier than what they can be at the start. So being able to have that really authentic grit in the conversation is awesome. So thanks so much for sharing that, Chris. So over to you, Sean. The GP with his feet on the desk. Is that you?
That's me. Yeah. Right here. No, thank you, Jess. Tēnā koutou katoa, everyone viewing tonight. My name's Sean Butler. I'm a general practitioner in Taranaki. I'm a director and part owner of Coastal Medical. So we own and operate 3 GP clinics in rural Taranaki, the towns of Oakura, Opanaki and Stratford. The reason I've been invited on tonight is 2 years ago, we started embarking on the journey to get paramedics into our clinic in Stratford to serve a pretty dire situation with clinician shortages we were having there, and really to serve, the acute care needs of the community at the time. So after a fair bit of groundwork, in March 2023, we went live with a pool of 3 ECPs. They were working in our clinic 2 days a week, and they had 30-minute appointment slots, seeing it around 10 patients per day. And this was a bit of a pilot stage. But fast forward to the present, and now we have a walk-in style acute care service, probably fairly similar to you, Chris. It's staffed by 1 or 2 ECPs Monday to Friday. At the moment, they're seeing anywhere from 20 to 40 patients per day. And that's our enrolled patient population, as well as casual patients from around the Taranaki region. And we had a lot of assistance from Shell to get it up and running, because we had minimal awareness of this whole thing. So we're eternally grateful to Shell for the help there. My initial thoughts and learnings are that paramedics are a really cost-effective option for providing care in the clinic, particularly acute care. And I think especially it will be useful in hard to staff areas like rural clinics. There is definitely some education and setup required prior to considering the model. You really need to have a good understanding of the paramedic scope of practice and training pathways, clinical supervision requirements, the legislation around standing orders, and as well as auditing requirements for those medications. But thankfully, unlike when we went through it, there's resources available now, and the work that Collaborative Aotearoa has done with their toolkit is fantastic. And there's also clinics like ours that have some real world experience, so you can learn from us as well. And webinars tonight are helpful too. So thanks again, Jess and the team, for inviting me on.
Yeah, kia ora. Thank you. And thank you for being so generous in sharing your learnings. I think that if we want to continue to evolve models of care in Aotearoa, we need to learn from the early adopters and our now innovators in the sector. So it's great to have you here learning, sharing all of your thoughts and feelings from being one of the first in Aotearoa to embark on that journey. So yeah, kia ora, and thank you for being a part of the toolkit. If you read the toolkit, you'll see that there's a feature on Avon Medical in Stratford there, and their journey to having paramedics providing acute care in their practice. Jacqueline, over to you. Kia ora.
Kia ora. Tēnā koutou katoa, ngā mihi nui kia koutou. Jess, tēnā koe, ngā ui whakawāti e tā tātou nei hui. Tēnā tātou katoa no, ko Waio, ko Jack Manley tēnei, ko au te kai whakahaere o te kaunihira manapau, no te whanganui a tāra ahau. Ka nui te mihi kia koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. So kia ora, it's a pleasure to join this evening. My name's Jack Manley. I'm CE Registrar for Te Kaunihira Manapau, the Paramedic Council. I live in Whitby, Wellington, with my husband Steve and our tamariki Devon and Keelan. So to avoid confusion, I'm not an employer. Te Kaunihira Manapau is the responsible authority appointed to regulate paramedic services, and that's under the Health Practitioners Competence Assurance Act 2003. So my comments are sort of from a regulatory point of view, but of course through lots of kōrero with our stakeholders. So I guess my initial thoughts, or our initial thoughts and learnings are, firstly, it's a journey. And it's an evolving journey. And as the regulator, we don't have all the answers, but we are working collaboratively to find answers that meet the purpose and functions of our Act. And that's to protect the health and safety of members of the public by ensuring that paramedics are competent and fit to practice. What's become really clear for us is education and communication are key. So these elements are necessary for the public and also for the healthcare teams. As you know, the idea of paramedics and extended care paramedics working outside of emergency ambulance services will take some adjustment. There needs to be a lot of education in that space, and that education will be integral to the success of the future moving forward. It's important that we're really clear about the scope of role, scope of practice, and how paramedics work within primary care. The other thing that's sort of come to our attention is the knowledge of the divide between an ECP working in emergency ambulance services and an ECP working in general practice. So consideration will need to be given to how we sort of recognise and manage these differences going forward. And I know that the education providers are already thinking about that. The other thing which I think we probably all agree on, and that's that general practice is different to emergency ambulance service. So a one-size-fits-all approach is probably unlikely to work. Primary care paramedics and other stakeholders, we're all currently working together to establish what governance and support looks like for paramedics in this space, and hence the toolkit developed by Collab Aotearoa is a great first step. So kia ora, that's probably it from me.
Kia ora, thanks Jack, and it's been great having you come in and share all of your knowledge around what paramedics can and can't do. Not much that they can't do, to be fair, but what they can do and how they can have an impact in the space. So it's been really cool having your expertise come in from that space, but also connecting us to all of those other parts of the system that need to be involved for us to be able to evolve this even further, including the education provider piece. So ngā mihi nui kia koe. Thank you so much for your contribution. And over to Byron. Byron, active member, going strong in the working group. Great to have you on tonight. Kia ora.
Kia ora. Kia ora. Thank you, Jess. Ko Byron Williams tuku ingoa. I'm the Extended Care Paramedic Lead for Tawara Compass Health. So about me, prior to being at Tawara Compass Health, I was working for an iwi provider, working in an outreach community space where we're trying to work with some of the more disadvantaged people in the community and actually getting them to re-engage with the health sector, and promote that re-engagement and work with them on addressing a bunch of unmet needs. Now, across the Tawara network, separate to that, across the Tawara network, we have a variety of models of which paramedics and extended care paramedics are employed into practice. We've got some that are employed directly by Tawara as the PHO and put into practice the same way we do other professional roles like health coaches and pharmacists. But also we've got some that are practice employed, and each one of those practices have integrated their paramedic or extended care paramedic in a different way to meet their population's need and their practice need. And it's really interesting to look at. And additional to that, we're about to do a secondment through Wellington Free Ambulance as well, where we're seconding somebody operationally from an ambulance context and putting them into a practice to re-engage their exposure. Because for me personally, my initial thoughts about paramedics and extended care paramedics being in practice is we do have a very broad skill set, and it is something to be considered when putting them as part of that primary healthcare team and that primary healthcare workforce. And part of the reason for putting them into primary healthcare is actually also to maintain them and keep them in the health workforce as well. Paramedicine and an ambulance, and I'm sure we're going to speak about this a bit later on, there is a bit of a lifespan to a paramedic being in an ambulance, and there's got to be some other options open up. Otherwise, we're just losing people out of the general workforce. So it's about finding alternatives to keeping people in the workforce. But as a practice, when you're employing somebody or considering to employ a paramedic or an extended care paramedic, you do need to ask some questions like what Chris and Sean have already touched on, of what are you trying to achieve? Are you trying to just address a workforce shortage, or are you trying to meet the needs of your urgent care population, or are you trying to do something like reintroduce home visits back into your practice, noting that that's a paramedic's bread and butter, home visits. That's what they've historically done through their entire careers, visit people in their home. Are you trying to find someone that can work with some of the most vulnerable members of society, or are you trying to find somebody to assist in some of your other parts of your team, for instance, your immunisations, because you're struggling to find people to cover those parts, because a paramedic can do that skill with some additional training. So what are you trying to find and what are you trying to achieve in your practice? And that's a question that very much needs to be asked if you're starting to look down this path, to be able to make sure that you pick the right skill set, the right person, and that they've actually got a bit of an introduction plan into how they're going to integrate into their practice.
Kia ora, Byron. Thanks for that. And so I think touching on that whole, the introduction into the practice and making sure you're really nailing that piece is really important. Cool. We'll go over to you, Shell. Kia ora. You've been in this space for a long time, and we probably picked up the back end of your mahi. So really great to have you on this call today, and really huge acknowledgements to all of the mahi that you've done to kind of steer the ship in this direction. So kia ora.
Thank you. So kia ora tātou. He tapuhi me he manapau kia Aotearoa. Ko pese toka whānau, ko Shell toka ingoa. So my name's Shell. I am actually a nurse and a paramedic, and all of this introduction of medics into primary care is actually born from my time in the military. So I served first as a grunt and then a medic, and then I was a nursing officer. So through my time, I actually saw paramedics work at a very extended scope within primary care centres within the military. So about 3 years ago, Steve Thrupp from the Matamata Medical Centre called ProMed, actually, which is a very small ambulance provider in New Zealand, and said, do they know someone that could come in and build a system for them to support their acute presentations in their rural general practice? And so Steve and I banged heads for about a year to come up with a bit of a model. It's a shame he can't be here to talk about this from their side. So that's quite a remote part of New Zealand as well, pretty poor access, pretty low socioeconomic, and so many people were just not getting access to GPs. But what we discovered is, even with my advanced nursing background, and I did my nurse practitioner training, I haven't registered as a nurse practitioner, but I'm also an ECP. I've done my ECP postgrad. Even with all of that information, that there were limitations and gaps in my practice. So I couldn't order bloods. I couldn't action those results. I couldn't order x-rays. And there were loads of things that we had to really look at and build education programs around. And so we've kind of gone through those ugly phases. And then we had integration with other health professionals and how that was challenging. And sometimes the nurses wouldn't understand what the paramedics were doing. And so I suppose some of it's a little bit uglier than we like to talk about, because paramedics are really highly skilled and they are really highly trained and they are very useful, but it's not a cookie cutter approach, and we do have to approach it in a gentle way, and I think collaboration is the best way. I really appreciate everyone else's comments adding to this as well, because I think together we can find a way forward.
Kia ora, Shell. Thank you for that, and thank you for your introduction to the rōpū. It's so good to have you here and your experience in that space. If you've gone through the toolkit or the guide, you'll see that there's all these like purple boxes that go workaround. This is what you could do to kind of like figure this out in the unperfect world that we're working in. And I think you've just touched on that beautifully. I spoke to somebody today who said, oh yeah, but Jess, paramedics can't get ACC funding yet, so we just can't do it. And I just, you know, my response continues to be, there's workarounds. You can do it. It's not as streamlined as we'd like it to be, but all of the right things are happening for that to happen, and we will see that come into policy soon, and we will be able to see our ECPs and paramedics claiming ACC and having that ability to have some autonomy. But don't let that be the thing that stops you from employing a paramedic into your space. And I think what we've heard from everyone on our panel just in the introductions is that you can do it. It is possible, and the workarounds are a bit niggly to start with, but you actually can get into a bit of a flow with it and just crack in and get it done. So it's not easy to start, but some of these people on the screen have done the starting for you, so you can just jump in behind them and take the lessons learned. We are going to just jump into our list of preloaded questions for you all, but please do use the Q&A function. We've got one in there already to start with, so we might just ask that first up, and it is, do most acute clinics that are run by ECPs charge a co-payment? And if yes, is this the same as when staffed by a GP? So we might just go, Sean, your answer, Chris, and then Byron, what are you guys doing at the moment?
Yep, we charge the same as if a patient is coming in to see a GP. We charge our enrolled patient population standard fee, and then we charge extra for a patient we're seeing casually who's not enrolled.
Kia ora. Chris?
Helps if the mic goes off. So we're very similar. We have, if the patient comes in the acute setting and is worked up by myself, and then we have some interaction with the GP, but they don't come and see the patient, then they're charged the fee for seeing myself. If they then are seen by the GP, then they get the consult fee from the GP, and my one gets effectively swallowed by the company. So it's they charge one fee to the higher of the skills used.
Kia ora, Chris. And Byron?
Yeah, kia ora. From a PHI point of view, it is practice dependent and does depend on the practice, the type of patient that is coming in the door as well. What we do know is a lot of our paramedics across the PHI do a lot of POAC claiming as well. That's something that's very top of mind for some of our paramedics to claim, and in fact, in some cases, they're seeing patients that might not have otherwise been able to be seen in some of the GP practices, which would in some cases need to go to hospital because they're utilising that POAC side and some of their additional skills which might not sit normally in general practice. We do have a group of paramedics currently employed across the country under special Te Whatu Ora funding at the moment, and for those paramedics they can't claim, and that's due to the funding arrangements with Te Whatu Ora. It's that pilot scheme, but that's quite unique linked to those. So there is a practice dependent part to it.
Yeah, I think you raise a really good point there, Byron. Any ECP or paramedic funded under the CPCT or the comprehensive care team funding cannot have copay attached to it. It does create a little bit of tension out there because patients don't know, like, why am I getting charged at one practice and not at another? So it is something that it's, I guess, another little challenge within our system that we've got to work through, and just a lot of patient education needing to fall into that space. But hopefully it's not in the same area or a town that we're having those challenges. And I know our PHOs have been really cognizant of some of the complexities with the funding coming in. So just something to be super mindful of in that space. The next question is for you, Sean, and then Byron and Chris to add in from your experiences from the other end. The question is, what specific benefits have you observed from integrating paramedics and ECPs into general practice teams? And what superpower do they have? What are the skills that you were like, man, I never knew they could do that, or really kind of been able to leverage in your practice?
Thanks, Jess. Well, look, for us, the big one is access. It's well known by everyone here that access to timely healthcare is really hard across the country, and that's particularly in rural settings like ours. I mean, our situation was pretty dire a couple of years ago, especially for the provision of acute care. I mean, I think in 2022, we had one full-time equivalent GP who was serving an enrolled population of about 7,000 patients, and there was really no acute care being provided out of the clinic, aside from maybe one or two patients who were usually just the first to ring up in the morning. So in the space of a couple of years, to go from that to offering a walk-in acute care service to the wider Taranaki community, and it's a service that the community's behind and quite proud of. It's something really special, and it wouldn't have been possible if we didn't decide to innovate. And there's a bit of, I guess, it was a bit daunting at times, but with the right support, the right people, we got there, and there's even more support now. So it's well worth considering. Probably another benefit we've found as well is the financial sustainability of the model. I'm sure there'll be some GP clinic owners or directors viewing tonight, and financially, life is pretty hard in general practice right now in New Zealand. But as a clinic owner, any new model that you look to implement does have to make financial sense as well, to ensure it's sustainable. So we've found that not only are paramedics a really cost-effective workforce, particularly compared to traditional alternatives to managing the patient load, like hiring a locum GP. But interestingly, in offering the service, we've had more patients than ever before request to enrol with us from the wider region. And we've actually had a number of GPs and nurses just wanting to come and join our clinic and our workforce because they've heard about what we're doing. They're intrigued by the different ways we have of working compared to the traditional model of care. So there's been some really good benefits in that space. With regards to superpowers, where do I start? There's a few. I mean, our experience of ECPs is that they're a really adaptable workforce. They're keen to learn, and they provide really safe and reliable care to patients. They also tend to have really intimate knowledge of the community and often individual patients because they've often seen and cared for them in their own homes. I would also say that one of their superpowers is their ability to stay calm, calm beyond measure, regardless of what walks in the clinic door. And from experience, I can tell you that as a GP in a rural setting, having a paramedic at your side when you're managing a case of sepsis or a STEMI is so reassuring. So they have plenty of superpowers, and we're lucky to have them.
Kia ora. Thank you. Love that. And I think when we spoke to your ECP when we were writing up the case study, I think he mirrored a lot of what you've just talked about. And I think one of the most compelling things that he said to me was, Jeff, I didn't know what medtech was. I had to learn this whole system, and I was having to tap the receptionist on the shoulder and be like, can you show me how to do this? And I think sometimes we've got to remember all the little things that they learn, but man, their superpowers to be adaptable and to learn and to pick it up and to come into that space is pretty compelling. So yeah, kia ora. Chris, Byron, did you have anything to add? Is there any superpowers that Sean missed off?
I think, Sean, you pretty much covered a lot of it. One of the big things that I was able to introduce when I came in was my skill set of triage. And I'm not talking about your phone triaging and that sort of thing. I'm talking about when it's 4 o'clock in the afternoon, all the doctors are running an hour behind or half an hour behind or whatever it happens to be for the day. And you have 5 people walk in within 15 minutes and they've all got chest pain or shortness of breath, or they've got some other acute bleed or something going on. In the paramedic ECP world, that's what we're used to. And so those sorts of things have been able to very quickly evaluate and go, yep, that one needs our attention. That one can wait a little bit. That one needs our attention. We're used to those very sharp, very short decision-making processes. So, and the calmness that does come with that actually settles the whole team down. And from the patient services team at the front desk, knowing that, hey, they can hit the emergency button and someone will come out that's as calm as they were when they walked in, ready to start their day and go, oh yeah, I'll deal with this. It can just actually change the whole process for that patient. And it's not a great big cluster. It's a controlled environment where the GPs can actually go back to doing what they're doing, and we can leave that STEMI sitting with the paramedic because that's what they've done and that's what they're used to. So from that point of view, it's a really good benefit for the clinics.
Kia ora, Chris. Oh yeah, got Byron.
Yeah, kia ora, sorry, Jess. And just from me, superpower that I feel most paramedics and ECPs bring, which other parts of the health workforce we try to integrate but don't necessarily fully understand or find it hard to relate to, is actually this ability to be able to work with almost anybody in society, because they're so used to walking into people's homes and actually seeing how different parts of society live, not just seeing people come on into a clinic. They've got a higher appreciation from that, and that's something definitely that's been echoed across our paramedic workforce that have gone into primary care, is they've got there's a no barrier approach to them. Not saying that there is barriers in other parts of healthcare, but for them it's a very much no barrier approach because they have been doing this for a long time, walking into people's homes. So they've actually walked into somebody else's own environment, which has been completely out of their control.
Kia ora, and kia ora, Shell. Still on mute.
Sorry, just to add one more thing. When I was in Matamata, we hired a paramedic, Kat Price, and she did point of care ultrasound. So as part of the ECP program, there are these extended skills. Now, most GPs are expert generalists, especially rural GPs. They do everything. These ECPs have got these very specific skill sets that are really useful to work alongside these very experienced GPs. And with Kat, she could, if it was after hours and there was no x-ray available, she could have a look and see if these bones were broken. We could make decisions about how serious patients were based on that skill set she had. Now, I've actually gone off and done that point of care ultrasound training, and I use that in Vanuatu for exactly the same reasons. But it was just an absolute superpower in the clinic.
Beautiful. Kia ora. Thanks for sharing that. That's awesome and so good to for our rural communities where access to diagnostics is really challenging, especially after hours. That's a massive superpower to be able to have. I think a lot of our rural clinicians find that really challenging, trying to make really good informed decisions with very little information. I just want to bring our panelists' attention to the chat. If you find something in there that you feel like you could answer, feel free to answer via text or typing, and then we can get through some more of the questions there. The next question's for you, Jack, and it's probably the elephant in the room. It's are we stealing a workforce from the ambulance service? We've heard all about how our ambulance services are really stretched workforce-wise, and they're really struggling to keep up with recruitment and retention of their workforce. And I think if I haven't had been asked this question myself probably 285 times in the last 3 months of all you're doing is, shifting the workforce problem around. I just think we need to address it, have a conversation about it, and just land the elephant with you to kind of address tonight. So over to you.
Kia ora for that, Jess. So there are obviously varying views on this, but Te Kauni Hiramanapo's view is that making it easier for paramedics to work in general practice is unlikely to make it more difficult to recruit paramedics in emergency ambulance work. So anecdotally, we are hearing that paramedics who are leaving emergency ambulance workforce are doing, because of whānau commitments, clashes with rosters, patterns, and a desire for change in their career. So our view is, rather than losing these valuable health practitioners entirely, it makes sense that they have career progression, opportunities where they can move into different areas of practice and continue to support the healthcare workforce. It's possible that they might choose to return to emergency ambulance sector at the future, so leave that open. But what I hope we might see in the future is a collaborative approach with paramedics working partly on the road and partly in primary care. Clearly that would be roster dependent, but I think that's the ideal going forward, and that does have a lot of support from the primary care sector. It's probably a bit more challenging at this time for emergency ambulance space, but let's hope.
Unmuting this time. Kia ora, thank you. There's a few questions in the chat too around how many paramedics are out there, and I know that those numbers are changing rapidly. How many ECPs are out there? I think the last count there was 3 in Northland, and I think they were all working in primary care, which was blooming awesome. But yeah, I'll leave you to answer those maybe online, because you'll no doubt have some stats that you can share with the group in that space. But I agree. I think we're all in this together. We're all trying to serve the same community, and we're all there to get the best outcomes for the whānau that we're serving within our hapori. So I think the other thing that was really compelling to me was having both St. John and Wellington Free a part of our working group and coming to the table and being really cognizant that we need to be in partnership with this. I think the challenge that we continue to face in this space, and Shell, I'm really keen on your impromptu question for you here, but I think from a personal perspective, someone wants to have one employer. They don't want to have multiple employers. So how do we solve the employment issue for a paramedic that maybe wants to do 3 days on the road and 2 days in practice, or 1 in 4, or whatever it is? But how do we enable them to have that balance? I'm really keen on your thinking, Shell, and I'm sure you've done some thinking on this, but where do you see that landing in the future?
So, I think employers working together is really important, and it maintains our workforce on the road if we are offering these external experiences as well. So I'm actually a casual for St. John in New Zealand, and I work for the Hastings Health Centre in the urgent care sector when I'm in New Zealand to keep up my registration. So I do see it challenging having the different employers, but I think if employers work really closely together, they can actually provide these opportunities for people. So here in Vanuatu, we have a significant shortage of medical professionals. So I'm CE of our ambulance service here in Vanuatu, and what we actually do is we provide extended care paramedics to our nearest general practice for a smaller fee. My extended care paramedics get experience in general practice, supported by really advanced nurses, which is really good to have that collaborative approach. And our community here get a primary healthcare access. So, and then my guys are on the road responding to emergency calls after that. So maybe something like that could be viable in the future.
Yeah, absolutely. I think it's a challenge we've got to put out to our employees in this space to see how we can really nurture the well-being of our paramedics and ECPs in this space and ensure that their employment well-being is really front and centre as we move through these challenges. And I know St. John are thinking about it. I know Wellington Free are thinking about it. We've had lots of discussions about it in our working group discussion. So it's great to have them really having that front and centre. And I know our general practices are really thinking about how they can best support their workforces in that space as well. Right, the next question is back to you, Sean, Chris, Byron, a little bit of on the ground, what's going on. The question is, what challenges did you face during the recruitment and integration of paramedics into your practice, and how did you overcome them?
Yeah, well, I mean, recruitment-wise for us, it actually wasn't overly difficult right at the outset. I mean, our area is pretty closely knit, and so basically through word of mouth, there are a few suitable ECP candidates that arose. But what was challenging is just what we're talking about, is actually enticing them to get involved with a new way of working. And that was especially considering the job security that they had with St. John. So early on in the piece, most ECPs were only willing to come on board just on casual contracts. They wanted to continue to work with St. John. They mostly did shifts with us on their days off, which is pretty understandable. I mean, the model was really new. They just wanted to test the waters. But it did make rostering quite a challenge because the St. John roster rotates and ours is fixed. So some days we had them in clinic and others we didn't. But with time that has changed and they've started to spend more time in our clinic. And our ECPs, most of them do still spend time on the road, which I think is great. It's quite possible though that clinics wanting to establish a model like this may have to go through a pilot period of sorts with the ECPs, let them experience life in the GP clinic on a casual contract. And in fact, we've just done the same thing with another ECP. There's come in as an observer basically to see what it's like, just to get a feel for things. With regards to other challenges, we have touched on it again, but most of the challenges are around things that can prevent the ECP from being completely autonomous. And that's the end goal here, right? Like, I mean, the model will never be really effective if the ECPs can see patients, but they have to tap the GP on the shoulder after every case and get them to do prescriptions and lab requests, etc. So we want our ECPs to be essentially autonomous. Medications is one of the main issues there. And as Shell has touched on, standing orders are what we use. For those that might not have a clear idea of how that works on a practical level, we've certified our ECPs to use standing orders that we established right at the start. There are about 25 conditions, common medical issues that we felt an acute care physician would come across. So everything from otitis media to ingrown toenails. We combine that as well as their existing St. John clinical procedures and guidelines. We certify them to work under those and our standing orders that we created. And so based on the standing order, the ECP provides medication to the patient in the clinic from our supply cupboard. And it's mostly made up of medications on the practitioner's supply order list. Each medication that they dispense comes in its own separate box for whatever the course of treatment is. So it's pretty effective and efficient. It's a workaround though. Similar story with things like lab requests. Our ECPs don't necessarily request a whole lot of lab requests. We have upskilled them to request certain things. things like throat swabs, for example, where there's clear pathway and guidelines. In our area, unfortunately, they can't request under their names, so they request under our names as the supervising GP. And similar with radiology, those requests have to come via us and off to the radiology service. But with these workarounds, I'd estimate that probably about 15 to 20% of patients seen by the ECP require some sort of input from a GP, and that varies to the level of input as well. It's often quite minor. It doesn't mean we have to see every patient that they see. It might mean that they just have a quickly chat to us about the patient, or we're just sending off a prescription after talking to them. It's overall reasonably effective. But something that then follows on from that, and another challenge, is also just ensuring that there's available clinical support for the ECPs. So there needs to be a GP, potentially a nurse practitioner, available for when there are patients who don't fall within the established ECP scope of practice. It's probably not ideal or sustainable for the clinician, the GP, to provide that support on top of the typical busy general practice patient load each day. So what we do is we have a GP on site, which we've labelled the support GP. They have a lighter patient load in their appointment books, usually around 7 to 8 patients per session or per half day, and they have gaps set aside in their day to be available to provide clinical support. So to review acute care patients, do prescriptions, etc. We're finding that the model works really well, and the GPs providing the support have given really positive feedback. They feel like they're working to the top of their scope, and the reduction in the patient load actually makes them have less administrative time, and they feel less risk of burnout. So it's a win-win in our books.
Kia ora. Byron, do you have anything to... We'll let you go before Chris this time.
Probably the first thing in regards to the train and recruitment and integration of paramedics in the extended care paramedic workforce, mainly considering around the extended care workforce, is that workforce does actually need to be trained in that locality prior to employment, because that extended care training does actually take quite a bit of time, good 12 to 24 months minimum, sometimes 36 months for that postgraduate diploma. So understanding that workforce needs to be trained potentially with an existing employer, or you're taking them on board into general practice as a paramedic and then slowly morphing them into an extended care paramedic. So just having that understanding that if your workforce in your area potentially doesn't already have that, your recruitment is potentially going to be a bit slower, noting that there are pockets of the country which for paramedics there isn't quite as many postgraduate staff currently working in, because in a lot of cases those people have to self-fund through that, and the employer, if they're working in an ambulance context, has to also have some sort of say as whether they support that currently through that ambulance context. So that's definitely one thing to think about if you are going down this recruitment line, is there already a pool in that area? Now, obviously you're not wanting to rob the ambulance service, but it's about giving additional options there for that workforce to help keep them in that workforce, because that workforce is looking for options and building that relationship also with that ambulance provider. The biggest challenge, like Sean just said, is in particular around medications. A paramedic and extended care paramedic is going to get disheartened quite quickly if they're having to knock on a GP's door asking for paracetamol and ibuprofen every 5 minutes, because they will unfortunately get met with a variety of responses from GPs in regards to that. So allowing them quite early on to be able to work to top of scope, and that's a huge challenge, and it's one that with the collaborative toolkit, new paramedics, including some of us that are also working in practice, should be able to slowly help resolve.
And Chris, anything further to add?
No, I think Sean and Byron are pretty much nailed it. I think one of the biggest things being the paramedic coming into that environment, particularly in some of the bigger centres, we've got an amazing set of nursing levels. And one of the things I probably don't think I understood, and I think there's a couple from my workplace here tonight, but we've got the nurse prescribers, we've got the community nurse prescribers, we've got the nurse practitioners. They all have a skill set that is different to what we offer as paramedics. And collaboratively, I think we've done a pretty good job of learning what each other can do, and that network of support of going, hey, can you have a look at this one so I don't have to go and knock on the GP's door because it's something I can't do but something that they can. And educating around what you have in your centre. Like some of the smaller centres don't have the ability to access these things, but then you've also got things in the community that you can link into, iwi groups and stuff like that, that we have the ability to say, yes, we've walked in people's homes and been invited in their doors, but we don't necessarily know what's available to us in the community because we haven't had the opportunity to knock on that person's door at 3 o'clock in the morning and say, hey, can you give us a hand with this person? So I think the education goes both ways. I learned a lot, and I'm still learning a lot from the nurses that we have in our centre, and vice versa. That sharing of knowledge is huge.
Kia ora, Chris. And I'm going to go slightly off script here because I feel like you've opened up a really good segue for us to wrap up our session tonight. We're going to finish off, team, with a final question, all of you to answer from your own world view. But are we going to see a prescribing paramedic in the future? Is that going to be the next thing? Is that something that's cooking up in the background that needs to or should happen? What's your views? What's your perspective? And yeah, share us as your kind of closing remarks and anything else you'd like to add in, just mindful of our time. So we'll start, Sean, with you. We'll go Chris, Shell, Byron, and then finish with Jack.
Thank you. Yeah, I do think we'll see a prescribing paramedic in the future. I mean, I think it's quite possible we see paramedicine within general practice become a subspecialised field, where paramedics might elect to have specialised training in community general practice and urgent care settings. I would love to see this prioritised for rural setting as well, but it will have its place in urban clinics. So they would be training in aspects of chronic disease, mental health, radiology, palliative care, and POCUS is a classic example where that's so beneficial. So yeah, paramedics, I think, will be able to prescribe, request lab and radiology investigations, and then there'll be appropriate service agreements for paramedics within funding bodies like ACC as well. I and my clinics were really excited about what the future holds for ECPs in our community. We found it really enjoyable establishing the model of care. It's great for our area, and so yeah, appreciate you inviting me on tonight to hopefully share some experience and knowledge about it.
Yeah, Sean, I think you've summed it up. I agree. I think there will be in time the prescribers. I think what we need to realise now, we all know EDs are falling over. There's no golden bullet that's going to fix that. Integration is key, and if we can cut it off at the coalface in the community before people get to that point, yes, we're always going to have the cases that end up in hospital, but if we can provide a service that is focused more about the patient and what we can do for them rather than the title on the door, then it can only be beneficial for the patient and our practices going forward. So yes, I think the skill sets will grow. This is infancy stuff that we're doing at the moment, and the work the collaborative is a great build on to what the likes of Shell and the guys have done in the last 10 years or so. But I think this will grow, and I think it'll become a normal integration for medical centres or general practice across the country.
Yeah, beautifully said, guys. I agree. I do think that having a prescribing practicum nestled in a primary and an acute care master's degree for paramedicine is the right way to go about it. I think there are so many additional papers I would like to have taken as an ECP, which I was able to do within my nurse practitioner practicum. So I think the future is bright, and New Zealand has welcomed nurse practitioners. They have led the path for us, so we can follow along those lines and remember the challenges that our nursing colleagues experienced becoming practitioners and independent prescribers. So we know the road is going to be challenging, but I think we are definitely moving in the right direction. And just to everyone, this is the beginning of the conversation. This is not the end. So as we grow and develop and adapt, I think there'll be more things available for everyone.
Yeah, kia ora. Absolutely agree that I can see paramedic prescribing as something that's coming in the future. There's no hiding that. It makes sense. You've got paramedics starting to work into practices now with that by adding things like standing orders, and we're actually removing some of the other professional safety checks that occur with prescription medications, which is the pharmacy. So actually one thing that prescribing does is it actually brings that safety check back in, which is a safety check that, to be honest, standing orders are a workaround for. It wasn't really what the legislation was written for. It's just something that's adapted. And if you look at the ambulance scope of a paramedic in New Zealand and how that's changed over the last 15 years, that's changed vastly. Chris, Shell will all absolutely agree that a paramedic 15 years ago might have had 10 medications, 15 medications. Now we're pushing for an ECP over 100 in an ambulance context, and forget what general practice can include to that, the amount of medications that can't be kept in a car because it's just not functional. It's absolutely growing, and rightly so. We've got a very well-trained workforce here that is looking for other options. And with that other options, it's about then keeping them in the health workforce generally. They're really trained in the emergency side, and it's about integrating them with that, but they're also trained really well in generalised assessment. So it's just about finding other ways of keeping them in that health workforce. So it's been great to be part of this to date, and yeah, absolutely, I can see prescribing coming down their lines in the not too distant future.
Yeah. Kia ora, and I can confirm that in 2026 we'll definitely have on our work plan to explore prescribing, and we can't do it sooner because we've got too many other big projects on the way, but we're aware that it needs to be done. You know, the lateral thinking and the interdisciplinary collaboration coming through now are going to be critical. I think we'll get workforce plans that leverage and celebrate our differences, and will hopefully be able to ease the pressures on practice workloads, waiting times, access. So yeah, I think there's a lot of exciting things coming. So kia ora.
Kia ora, Jack. How exciting is that, and great to finish with you. It would have been a bummer if we'd started with that bombshell and then gone the other way around. So that was by accident that I made that order, but great to have you kind of wrap that up at the end. Huge thank you to all of you for all of your mahi that you're doing in primary care and general practice, for all of your courage to lead with innovation and to try something new, and to invest in a new workforce or be that new workforce coming into the space. That takes courage. It takes a lot of time and a lot of energy and a lot of thinking and resourcing. And I think without people like you on our panel today, things like this just wouldn't happen. So from the sector to you, ngā mihi kia koutou. Thank you for being the kaitiaki, the rangatira of this kaupapa across Aotearoa, and keep doing your do, because the rest of the sector are looking at you for all of the answers in new workforces coming in to save the day. Finally, just to wrap up, if you are new to the collaborative space, head along to our website. That's where you will find the toolkit. We're asking that you don't print too many copies, because we're hoping that we can evolve and update some of the content as we go and as things change and as legislation changes and things happen. So we aim to keep that a really live document and keep it updated as things progress, including an update on where where we land with the standing orders. If you do need any specific resources, do feel free to email admin@corelab.org.nz and we can flick them through. Kiriana, I've got a whole lot of JDs coming your way, and anything else that you need in that space, we're really happy to uffy and support. So just reach out. And we're going to close out tonight with karakia. My sister has just had twins. She just tried to call me in the meeting, so I'm super excited to meet my two little nephews via FaceTime in about 35 seconds. I'm going to wrap us up and I'm going to go and meet them, but exciting to share that with you all as we go. Wrapping us up, closing us out, have a great evening, everybody. Manawa mai te mauri nuku, manawa mai te mauri rangi, ko te mauri ke au, he mauri tipua, ka pakaru mai te pō, tau mai te mauri, haumi e, hui e, tae
Tai
ki e,
ki e.
ka ki te koutou.
Ka kite.